Good evening, everyone, and welcome to Sleep and Fatigue Strategies for Arthritis webinar. My name is Sarah Dillingham. I'm an Arthritis Foundation volunteer, and I also run a patient Facebook group called Women with Rheumatoid Disease. I've been living with rheumatoid arthritis for over 20 years, and like many other arthritis patients, I find fatigue and sleep issues to be some of the most challenging symptoms to manage. So I'm excited that this evening's guest experts will discuss a range of solutions to help you get better quality of sleep and improve fatigue. Events like this are informed and driven by patients like you. With your input, the Arthritis Foundation can create more educational tools, resources, and programs that will speak to what's really important to you and help you live your best life. That's why I'd like to share a short video with you to tell you about the Arthritis Foundation's Insights program so that you can make your voice heard and help us create more programs like this one.
By taking part in the Live Yes Insights Assessment, you help change lives today, including your own. And you help change the future of arthritis. It takes just 10 minutes or less to share your experience and make a difference. Answer simple questions like how often you felt arthritis pain in the last week. Ongoing insights data from people like you will lead to new resources that ease daily life. Your insights show what kind of support you need in your community. You improve the healthcare system. You focus researchers that's funding possible, leading to new groundbreaking treatments. The power is in your hands to change things now and for the future. This is your opportunity to change the future of arthritis.
Okay, so just a note following that video, the Arthritis Foundation has recently launched its JA Insights program and strongly encourages parents to enroll in that program as well. So before we begin, I'd like to share a few announcements about tonight's event. We have muted all attendees for this event, but you can direct any questions you may have throughout the webinar into the Q&A box on the bottom of your screen. We will reserve some time to answer your questions at the end of the presentation. After tonight's session, you'll receive an email asking about your experience. These surveys help us track the success of these sessions and better plan for future events. So let's get started. Our first guest expert is Dr. Michael T. Smith. Dr. Smith earned his PhD in clinical psychology at Alliant International University in San Francisco, California, and completed his general clinical psychology internship and fellowship training programs in both pain management and sleep disorders research at the University of Rochester School of Medicine. His NIH-funded research focuses on the neurobehavioral causes and consequences and treatments of insomnia and sleep loss, with an emphasis on the interface between sleep and pain. Dr. Smith serves on several editorial boards, governmental advisory panels, and NIH research study sections. He is a co-founder and past president of the Society of Behavioral Sleep Medicine. Dr. Smith, welcome, and thank you for joining us tonight.
You know, this is a graph. People are always asking me, how many hours of sleep should I get a night? And this data shows that these are self-reported data from over 1 million subjects, and it just shows on the y-axis what's called all-cause mortality, so your risk of dying from any single cause, and on the y-axis is your overall self-reported sleep. total sleep time on a habitual basis. And so you can see there the green zone, and this is at a big, large scale, million epidemiologic level. The green zone of good sleep is actually 6.5 hours to about 7.5 hours for an adult. And everybody in this audience has a certain amount of sleep that they need, but typically it falls within that band of about 6.5 hours to about 7.5 hours. And what this slide shows is that when you go either lower than that, so when you get on average, the population, as people start reporting less than 6.5 hours of sleep per night, their risk of all-cause mortality or dying starts to go up significantly. Also, you can sleep too much. And so as an adult starts to report, upwards of 8.5 hours of sleep per night, that's typically a little unusual. And that's related to mortality. And this slide is controlling for all sorts of other chronic conditions. And it sort of illustrates this sort of sweet spot that it's about 7.5 hours for an adult, give or take, half hour or so. That we need. And then this slide also shows you that sleep deprivation or insufficient sleep is incredibly common. It affects at least 38% of the adults. And so it has major consequences. You see the aftermath of the Exxon Valdez oil spill, which when they went back and they did an autopsy of what happened, not only was alcohol involved, but more importantly, actually, sleep deprivation was involved. The crew, including the captain, had been working night and day to unload to come bring the ship into port and to unload some of the oil, and so they were sleep deprived, and that was part of the cause of the accident. Next slide. So when we think about this, a very busy slide. I usually just slow this down a little bit, but these are a bunch of different circles. And when we think about sleep in chronic pain populations like osteoarthritis or rheumatoid arthritis or some of the other arthritises, you see that the two most common sleep disorders are insomnia, trouble initiating or maintaining sleep, and chronic pain are highly overlapping. So patients with arthritis and chronic pain, typically 50 to 88% of them report clinically significant insomnia. But why this slide is so important is that there's lots of other sleep disorders, and so that have higher prevalence in arthritis populations and chronic pain populations. And so there's a sleep disorder called sleep apnea, and that's a disorder where you're not breathing and your brain is not getting adequate oxygen at night, and that is a significant problem. And so if you just have a complaint of poor sleep, what this slide really is showing you is that you need to go to the doctor and get a very thorough assessment to try to understand what might be causing the insomnia. Even if you have pain, and pain does cause sleeping problems, the chances are you actually have other very important sleep disorders that may need specialized treatment. And so there's a treatment for insomnia, and that's what I'm going to talk about today, which is the most common sleep disorder. But treatments for sleep apnea, for example, are a completely different treatment, and you still may report similar symptoms. There are other sleep disorders called restless leg syndrome. There are problems with your brain's clock that governs when you wake up and when you go to sleep. So people who have really prolonged time trying to fall asleep at night have something called a delayed sleep phase, where their clock is putting them to sleep much later than usual and making them sleep in much later than usual. And so there's a lot of different disorders that really require specialized assessment. Next slide, please. So another important thing to think about if you have sleep disturbance and a pain condition are that a lot of the medications that you may be taking influence sleep in lots of different ways. And so this is a table, and hopefully you'll have access to some of this information afterwards. But this is a table just showing the effects of various common classes of medications that you might be taking and what they do to sleep, and that sleep architecture from that diagram that I showed you. And one type of medication I want to point out is that the opioids, things like morphine or OxyContin, those medications may help you kind of fall asleep, but they actually reduce the deep sleep that you have, slow wave sleep. That's what the SWS stands for. And they actually reduce REM sleep, the amount of dreaming that you have in the middle of the night. And they increase the lighter sleep. So opioids aren't good for your sleep. They may help you fall asleep, but they interfere drastically with sleep. And the other thing that opioids do is that they actually cause sleep apnea, like that problem that I was talking about before, when you have you're breathing, you're not breathing properly at night. The opioids reduce your brain's drive to breathe, and that can cause your brain to stop breathing for periods at the middle of the night, and it can cause either arousals and what's called hypoxemia, when the oxygen levels are lower than they need to be, and it causes a lot of problems with your physiology. You can see lots of other medications here. So the take-home message is that you need to talk with your doctor, bring your list of medications, and talk to your doctor about what they may or may not be doing to your sleep, so that you're taking ones that optimize your sleep and not taking a lot of medications that are interfering with your sleep. I'd like to point out that there are a lot of medications that interfere with sleep. There are also some that for pain that actually improve sleep. And so the anticonvulsants, things like gabapentin or pregabalin, which are used often in cases of fibromyalgia, actually improve sleep, and they improve the deep sleep that we think helps with pain processing. So there are some pain medications typically used for neuropathic pain, but also for rheumatologic conditions like fibromyalgia that actually promote sleep. So that's an important point. Next slide, please. So how are sleep and pain interrelated? And in the beginning, on the point number one, the traditional way of thinking about it is that it's pretty straightforward, right? You have pain, that causes arousal, and that interferes with sleep. End of story. If I want to improve sleep when I have arthritis, all I need to do is get rid of the pain, and I should be able to sleep. And that part of the relationship is certainly true. But the opposite is also true. There's been a lot of research, some of my own research and research from many other research labs across the world, which have shown that various forms of sleep deprivation, you can take a healthy person who has no pain whatsoever, bring them into the lab and sleep deprive them for one single night, and then measure their pain processing and their pain sensitivity objectively, and they will report, they'll have an increase in pain. Their physiologic pain thresholds get lowered with different forms of sleep deprivation. We showed that you could, if you interrupted sleep in a pattern that was similar to insomnia, so we gave people an 8-hour opportunity to sleep, and every hour we had people come into the room and wake them up for 20 minutes. And they did that all night long, and they got about 4 hours of sleep total. When you did that after 2 nights, that impaired your brain's ability to regulate pain and caused pain sensitivity and spontaneous pain in otherwise healthy people. So this relationship between sleep and pain is really, really important. And I would argue it's a really important way for you to manage your arthritic pain, because we know that sleep loss is going to aggravate and increase arthritis pain. Next slide, please. So those were the sleep deprivation studies, but that relationship between sleep and pain has been shown in what we call longitudinal studies. So if we take healthy people and we just measure them for up to a year or 2 years, and we measure a lot of them, and so we take healthy people that are pain-free, and we just see if they have sleep disturbance, do they have a higher rate of developing a new onset pain disorder, like a chronic pain condition? And the chances are yes, and that the risk is pretty highly elevated. So if you're a relatively healthy person who has insomnia, trouble initiating sleep or maintaining sleep, you're at a 2 to 3-fold risk for developing new onset chronic pain within about 1 to 3 years. And that's over 10 or so big, large epidemiologic studies. What's interesting is the opposite is true. So if you have a chronic pain condition, in this case, there was a study by Davies in 2008, and they studied people with fibromyalgia pain, widespread pain. And they showed that if you had widespread pain, which is often very hard to treat and difficult and often doesn't remit, but if the people with fibromyalgia that actually reported having good restorative sleep had a 3-fold remission rate of actually getting completely better from their fibromyalgia pain. So it goes both ways, that if you can improve sleep when you have a chronic pain condition, typically you can improve your pain condition. Maybe not get rid of it completely, but you can definitely help improve the level of pain that you're experiencing. Next slide, please. So now I'm going to shift gears. So I've already told you that sleep loss and sleep loss alters pain sensitivity, and insomnia, trouble falling asleep and staying asleep, getting an insufficient amount of sleep at night, is a risk factor for developing chronic pain and for aggravating chronic pain. What do we do about it? So Insomnia is one of the most common sleep disorders, and that simply is trouble initiating and maintaining sleep. Usually we think about it if it takes you about 30 minutes to fall asleep, or 30 minutes or more, or you wake up in the middle of the night for about 30 minutes or more, 3 days a week for about a month, that would be considered clinically important chronic insomnia. Now, with insomnia, we need to rule out all those other sleep disorders. So sleep disordered breathing, like sleep apnea, restless leg syndrome, all these other sleep disorders. But if turns out you have insomnia, there's really good treatments for it. And like I said before, most patients with chronic pain and arthritis, about 50% of them have chronic insomnia. So this model is a way of showing you and illustrating how chronic insomnia develops. And the blue graphs down below, that line, that threshold line, are what we call your premorbid predisposition, or your kind of your tendency, your biologic genetic tendency to have insomnia. And if you look at the line, the dotted line is your threshold for having insomnia symptoms, so trouble initiating and maintaining sleep. And so you take an individual with their kind of predisposition for having insomnia when things get difficult, stressful, or when you have pain, and this shows you how insomnia evolves from an acute problem to a chronic problem. So we call it the 3P model. So often you have a predisposition to insomnia, and then there could be some precipitating factor. That's the second P. Precipitating factor could be arthritis condition, or it could be a pain, or it could be stress, financial stress, doing your taxes or something like that. That kind of stress or pain is going to cause insomnia symptoms. But then what happens is that in the short term, your body's designed to handle that. But often that's such a noxious, unpleasant experience to have trouble falling asleep and staying asleep that you started trying to adapt to try to fix the problem. So what do? You sleep in on the weekends. You start using alcohol, for example, or doubling up on your pain medications to try to get more sleep. Taking naps during the daytime. Sometimes you just spend a lot of time laying awake in bed thinking about your pain. Or if you have pain during the day, you spend a lot of time in bed coping with the pain. And what can happen is all of those things that people do to try to improve their insomnia actually often make it worse. And so you can see what happens is even after that acute precipitating factor, say it's a financial stressor, after that goes away, the way people adapt to pain, these perpetuating factors, kind of can keep the insomnia going on and on and on and on. And we have to deal with those perpetuating factors to treat the chronic insomnia. So that's the kind of general idea for how what I'm going to talk about next, cognitive behavior therapy, works, because what we're going to attack with cognitive behavior therapy is these perpetuating factors. We can't can't completely get rid of the pain, but we can get rid of all the other aspects of how we try to cope with it that make your sleep worse and that can keep the insomnia going on indefinitely, because it becomes this vicious cycle. So next slide, please. So cognitive behavioral therapy for insomnia is a brief treatment. It's usually about 4 sessions, sometimes 2, sometimes 8, but it's usually, pretty brief. It's covered by insurance, and you can go look up sleep disorder centers at any major academic medical hospital in the country, and they should be able to point you in the direction of someone who can do this type of therapy. But it's a brief therapy. It involves keeping a diary of your sleep symptoms and making changes to your sleep patterns that address those maladaptive perpetuating factors. It typically, the 3 circles that I have here, the treatment targets a lot of different aspects of factors that drive insomnia. So your arousal, hyperarousal level, your tendency to worry at night. Often people get in the habit of, they're so busy during the day that when they actually go down and lay down and go to bed, that's when they get in the habit of thinking about all their troubles, or just actually they're no longer distracted and they start feeling the pain even worse. It also deals with the clock, right? I was telling you before that your body has an internal clock that governs when you wake up and when you get sleepy. And that clock can get out of whack, and we can manipulate that clock with light, properly timed light, and sometimes even melatonin. The other factor that cognitive behavior therapy addresses is something called homeostatic dysregulation. And it's a fancy term, but what it really means, and it's an important concept for improving your sleep, is that sleep is like a drive, just like hunger is. And so everybody has a certain amount of sleep that they need in order to feel rested the next day and in order to have their body function at optimal levels. And that drive to sleep, when you get less of it, it's just like a thermostat. Your body's going to kick in and force you to try to get more of it. And so in the same way that if you go without eating, you're going to get hungry and hungry and hungry, and eventually you're just going to probably break down and start eating. Same thing with sleep. And we use that concept in the treatment to help consolidate your sleep, and I'll explain that in a minute. Next slide, please. So this slide just illustrates that one part of the circle that's really important, and that's the clock. And this is just a CT scan of a person, and the part right where that arrow is that says SCN, that is called the suprachiasmatic nuclei, and that's your brain, your body's master clock. And it's situated right where it is because it's receiving input from your eyes, from the optic nerves in your eyes. So that's why it's called the SCN. In Latin, that means above the where the optic nerves cross. And so that little part of your brain, deep in your brain hypothalamus, regulates when your body gets sleepy and when your body wakes up. And that can get shifted when you don't, when light is not of the right intensity and you're not being exposed to light at the right amount of time. Light can also at the wrong time. So if you wake up in the middle of the night and you turn the lights on, keep them on, or you're playing video games, that light suppresses a hormone that regulates this clock, and that hormone is called melatonin. And melatonin is suppressed by light. So melatonin is darkness, the darkness hormone. When it gets dark, melatonin comes out. It tells your body to get sleepy. And when light comes into the eyes, it turns off the melatonin. Next slide, please. All right, so now I'm going to talk about the components of cognitive behavior therapy. So if you were to go to a cognitive behavior specialist in one of these academic medical centers or in private practice, they would do a bunch of different things to help put your sleep back together. The first two are the ones I'm going to talk with you the most about. One's called stimulus control therapy, and the other is called sleep restriction therapy. And there are a bunch of other components that I won't have time to go over. I'll talk a little bit about melatonin because it's so important for pain. So next slide. So stimulus control therapy. So any cognitive behavior therapist is going to initially do this therapy with you. And it's the basic idea behind it is that your bed and your bedroom can become a strong cue for sleep. It's kind of built into our learning as an animal. Even like dogs, for example, become conditioned in this way. And so what we call good stimulus control, it just means that when you're in your bed and bedroom, you're doing very little other than sleep. And that establishes a good stimulus control, a good relationship between your bedroom and sleep happening. And unfortunately, poor stimulus control is the opposite. So can you push the slide, please? Thank you. So poor stimulus control is what I show you on the screen. That's when you're pairing your bed and your bedroom with everything but sleep, and all these other things: eating in bed, reading in bed, TV, worrying in bed, going to bed when you have a pain flare. That's probably one of the most common things that I hear is when people are in pain, they don't feel like doing anything, so they go and they lay in their bedroom. What happens when you pair your bedroom over and over again with being in pain? Your bed and bedroom can actually act as a cue that actually causes your body to get hyper aroused as if it's going to experience pain, and that's incompatible with sleep. And so stimulus control theory really is about reestablishing your bed and your bedroom with sleep and only sleep. Next slide, please. And push the button one more time. And so what we're trying to do is break those associations between your bed and your bedroom and all those other things and reassociate your bed and bedroom only with sleep. And believe it or not, just doing that alone will help improve chronic insomnia. And I'm going to talk about the instructions for stimulus control in just a minute, but I wanted to try to explain why we would have you do these things. So next slide, please. There you go. So these are the classic, what are called stimulus control instructions, that when you go to a cognitive behavioral specialist to help improve your insomnia, they're going to have you do these things. And they sound pretty easy, but they can be kind of hard to do. But basically the idea is we're reassociating your bed and bedroom with sleep. And you're breaking the association between your bed and pain or being aroused or awake or doing different things. So the instructions are, don't use your bed or bedroom for anything but sleep. Go to bed only when you're sleepy. If you're not asleep within 15 to 20 minutes or so, get up, go to another room, keep the lights down because you don't want to suppress melatonin, and don't only go back to bed when you feel sleepy. And repeat as often as necessary. So the idea is you don't want to do anything in your bed and bedroom other than sleep. So if you have if you have a desk in your bedroom and you're used to doing work in your bedroom, try to find another place to do that. And the other big important thing is get up at the same time every day and no napping. So these instructions sound easy, but it's very hard in the middle of the night. If you wake up, for example, and have a pain attack in the middle of the night, and you're awake for about 20 minutes, I don't want you looking at the clock because that's a cue to be kind of awake and annoyed. But if it's been about 20 minutes and your mind is racing and you're getting frustrated, you don't want to pair your bed and bedroom with that state of being because that's incompatible with sleep. So what you do is you get up, go to another room. You can watch TV, but don't get too close to the TV because you don't want light in your eyes. You could read a book as long as you're using one of those night modes on your Kindle or something, or you're illuminating of the book with just a light, and just do something kind of boring and don't bother going back to bed until you're sleepy. So those are and you do that, and usually the first week that you do it, you're getting up and going back and forth, and it's really annoying. But you're reassociating the bed and with sleep and only sleep. Okay, so next slide. That was stimulus control therapy. The other big bread and butter intervention that we know works from all sorts of randomized controlled trials is something called sleep restriction therapy. And this therapy is really good, especially for patients with arthritis who often have very fragmented sleep. And so if you look at the first diagram called baseline insomnia up on the top, that is a diagram of what we call mixed insomnia. So you see the yellows represent wakefulness. So this is a person who got into bed at 11 p.m. and then didn't actually get out of bed until 10 a.m. So they were in bed for like 11 hours, right? And you can see that they only slept in these 3 periods, and they had a lot of these yellow periods in the middle of the night. So their sleep was really fragmented. We call that poor sleep consolidation or poor sleep efficiency, because when they're in bed, they're awake as much as they're asleep, right? And so that's that idea of you're pairing your bed with being awake. That's what your bed's going to be associated with. It's not going to be associated with sleep. So what we do with sleep restriction therapy is we use that idea of the sleep homeostatic, that sleep is like a drive. So what happens with insomnia and pain-related insomnia is that people are partially sleep deprived because they have insomnia, right? So maybe they're getting 6 hours of sleep a night or 5 hours of sleep at night. So they're getting all the negative effects of partial sleep deprivation, but they're also hyper aroused due to their pain and due to this conditioning effect. So what we need to do is override that arousal system, and we do that by taking advantage of that sleep as a drive. And so we try to, the overall goal of sleep restriction therapy is to consolidate your sleep, and to do that by partially sleep depriving you for a week or so. But it's not as bad as it sounds. But the way to illustrate it, we have you keep a sleep diary. So I told you before that cognitive behavior therapy is involved in you monitoring your symptoms. So in the morning, you fill out a brief diary that asks basic questions about, when you went to bed, how long it took you to fall asleep, when did you wake up, how much time were you awake in the middle of the night, those kinds of things. Do that every day. And we figure out how much total sleep time are you getting on average in a given week. And so if you say, for example, and this illustrates, say you're getting about 5 hours a night, but you're in bed for 12 hours, that's a problem. So what we do initially is we curtail the amount of time you're spending in bed to match just the amount of time that your body's generating sleep. So if you're getting 5 hours a night, then we move your bedtime really late. We fix your wake time. That's really important because that will set your clock. So we want your clock to be knowing that it's getting up at the same time every day. But so we have you go to bed, and we have you go to bed such that your opportunity to sleep is only 5 hours. And this would be a real extreme case, but this is what we do. So you get up at 7 a.m. You set 2 alarms if you have to. You tell your husband or your wife, wake me up at 7, and I don't care how tired you are, you got to get up. And you go to bed at 2 o'clock in the morning, and you do that for a week, right? And so what does that do? You get generally a little bit less sleep than you normally do, because in order for you to get exactly the same amount, you have to sleep 100% of the time efficiently from 2 a.m. to 7 a.m. And initially when you do it, you're not as efficient, and so you actually get a little bit less sleep, but that's increasing your drive to sleep. And so it's taking advantage of that homeostatic process. So by the end of the week, you're typically sleeping what we call 90 normal sleep efficiencies. So you're sleeping, when you get to bed at 2 a.m. in the morning, you fall asleep within 10 minutes, and you're out, and you wake up maybe once to go to the bathroom, and you sleep solidly from 2 a.m. to 7 a.m. When that's normal, then so the next week we look at your diaries, and if you're sleeping, and if your sleep is now consolidated, then we back up your bedtime, so you're going to bed 15 minutes earlier. And so what we do is we crunch sleep and get it sleeping solid in a nice chunk, and then we kind of wind it back based on how efficient you are at sleeping. And so the first 2 weeks that you do this, you're really tired, but your sleep is solid and normal. When your sleep is solid and normal, that architecture and the cycling is normal. The cycling gets out of whack when you've got all these awakenings throughout the middle of the night. So the first step is, let's just get your sleep solid, and maybe have you sleep a little bit less than you normally are. But once it's solid, then we're going to back you up and do it very slow. We don't want to back you up too fast, because that's going to break it apart. And so that's the nuts and bolts of sleep restriction therapy. It usually takes about 3 to 4 weeks. And by 3 to 4 weeks, you're getting more sleep than you were from the beginning, but it's solid. Next slide, please. So this is just a fancy slide that just shows you, I did a study a long time ago, so almost 20 years ago now, where we took all the literature of sleeping pills and all the literature for this type of therapy that I was talking about, cognitive behavior therapy, and we compared how effective they were. And so it's a study of all the studies. And what we showed was that on all the different major sleep parameters, that cognitive behavior therapy for insomnia was as effective as the best sleeping pills that were available. And those are all the same ones that are being used for the most part now. So things like Ambien and all the different benzodiazepines, and isoprolol. And so that study basically showed that there isn't much of a benefit for some of these sleeping pills compared to this treatment. And the benefit of the treatment is that once you get it, you kind of know what you need to do to fix it and keep it fixed for the long run. Whereas with a sleeping pill, you may need to actually, you have to keep taking the sleeping pill. So that's the some of the evidence is showing that this form of therapy, it avoids all the downsides of drug interactions, and becoming dependent on some of the sleeping pills can cause dependence. They can interact with your pain medications. So with cognitive behavior therapy, you don't have any of those downsides, and it lasts as long, and it's just as effective. The only real edge that the sedative hypnotics, or that the drugs like the Zolpidem and the Ambien, the only benefit is that you can often get an effect right away. But so you might get an improved sleep for a few nights. But over time, as you keep taking those to sleep, their effects can wear off. And so then in the end, you're going to wind up with insomnia as it is. And so that's why, next slide. So that's why all these different regulatory bodies really recommend for older adults, or for adults, that cognitive behavior therapy is the first line treatment for chronic insomnia, not sleeping pills. It's not that sleeping pills don't have their place, and maybe we can talk about some of that in the question and answers. But the NIH, the American Academy of Sleep Medicine, the American College of Physicians all recommend cognitive behavior therapy for insomnia, involving those two components that I talked about before, stimulants control and sleep restriction, as the frontline treatment for chronic insomnia. Next slide. So what about clinical trials of cognitive behavior therapy for insomnia in chronic pain? There have been at least 7 studies now, and this is a complicated slide, but I can summarize the data pretty easily. the cognitive behavior therapy for insomnia works in patients with chronic pain. And if you can look at some of those disorders, you can see that a lot of those are rheumatologic conditions. So fibromyalgia, osteoarthritis, neck and back pain, fibromyalgia, another study of fibromyalgia. I did a study, I guess about 5 years ago now, in chronic knee osteoarthritis. It was a randomized double-blind placebo-controlled study that actually used objective sleep measures. Most of these studies use sleep diaries or self-report measures, but we used a wrist actigraph as well as polysomnography, measuring your brain waves. And we showed that cognitive behavior therapy for insomnia compared to placebo, a placebo intervention, was better. It beat placebo, and it beat it for both sleep diary and self-reported measures of sleep, but also for the objective measures of sleep, especially what's called wake after sleep onset time. So the amount of time you're spent awake in the middle of the night really decreases with cognitive behavior therapy. And so the effect sizes, or how good cognitive behavior therapy is compared to the primary insomnia literature, is just as good. There's no decrement. So early on, people thought, well, how is cognitive behavior therapy going to work in patients that have chronic pain? Because pain is the problem. It gets back to that idea that pain is driving the sleep problems always. And it turns out that when you actually do the studies, that the treatment works just as good as it does for people who have only insomnia and no pain. Now, what's interesting, because I already talked to you earlier, that we know that sleep deprivation and insomnia is a risk factor for pain and for chronic pain. The question becomes, what happens if you treat insomnia using cognitive behavior therapy? Does it actually improve pain? And so the answer to that question is most of the studies like that I'm showing you here were really designed just to answer the question, does cognitive behavior therapy work in chronic pain populations? The answer is yes. They weren't really designed, you can see the sample size is relatively small, meaning there's 60 subjects, 40 subjects, 51. There's some larger studies now, but what we find is that the studies of cognitive behavior therapy tend to improve pain, but not as strong. And so the findings right now are a little bit mixed. There was a meta-analysis done in 2015 by Nicole Tang, who showed that cognitive behavior therapy for insomnia and chronic pain seems to improve pain significantly, but the effect sizes are small to moderate, which is still really good. But the caveat there, which I was trying to say before and wasn't getting that out too good, is that the studies weren't designed to do that. And what we probably need to do is we need to adapt cognitive behavior therapy so that it's better suited for chronic pain, so that we can actually really realize the benefit of improving your sleep on improving your pain. So more research is needed to really drive home the point that if you treat insomnia with cognitive behavior therapy, it will improve your chronic pain. Next slide, please. This is just a slide we did. I told you I did a study in knee arthritis patients, and we measured, and I just thought it would be important to show that improving sleep, at least in the short term, in our study, has some really important physiologic and objective effects on not only on pain. We did find that it improved pain, but it also improved your body's level of inflammation. So that IL-6 slide on the left shows you that the group that got, the orange group that got cognitive behavior therapy for insomnia, that they had reductions over time from baseline to 3 months in this what's called a pro-inflammatory cytokine, which is kind of part of it's a chemical in your that your white blood cells produce that is part of your immune response, and it's in normal situations it's good, but we can have especially in cases of rheumatoid arthritis or even osteoarthritis, you can have elevations in inflammation. And inflammation, we know that chemical, although it's really important for the immune system, it actually causes you more pain. It actually sensitizes your pain receptors to be more pain sensitive and to actually transmit pain. So we showed that cognitive behavior therapy for insomnia in older adults with knee osteoarthritis, compared to baseline, it reduced levels of inflammation, circulating inflammation in your blood at 3 months. Now, we lost that effect at 6 months, but we had a bit of an attenuation in the insomnia. Insomnia came back. And so what we learned from that study is that when we do cognitive behavior therapy, you do generally get effects that last 3 months and often up to a year or two. But in chronic pain, we might need to do some booster sessions. We just did, we did 6 sessions, and then we just measured them over time. And we showed that pain got better at long term, and that inflammation got better at 3 months, but there was a reverted back. The other slide on the right shows that actually people with knee arthritis were able to walk more on what's called a 6-minute walk test. So we just have people walk as fast as they can, and it hurts, but walk as fast as they can in 6 minutes. And we measure the distance that they walked. And we showed that cognitive behavior therapy in and of itself improved people's ability to walk. And that was significant at 3 months. Next slide. So I'm going to stop soon, but I mentioned before that I think what we need to do, the new research is really looking at how do we adapt cognitive behavior therapy and modify it so that it maximizes pain reduction. And so there's a few things that I think we can do and emphasize in cognitive behavior therapy, and maybe these can help you if you try them. And one of them is using a white noise machine, and white noise machine, and this is a picture of one that you can get on Amazon.com. There's nothing special about it, but white noise is a very monotonous sound that doesn't have it's just one kind of tone basically, and it drowns out environmental sounds. One of the things that we know that pain does is it causes your brain to be on alert, because that's what pain means to your brain. Pain means something's wrong, tissue damage, bad things are happening. And so when you're in pain, you're hypervigilant. And we've done studies showing that pain patients are more easily aroused to environmental noises. And so one little trick that you can do is make sure that you're not bothered by sound, because normal sounds that might not bother someone without pain are going to bother someone with chronic pain. And so a white noise machine is a simple thing you can buy. It costs $40. You just want to make sure that it's white noise and not some of these things you can buy. There are tapes of like ocean waves and birds chirping and things like that. Those kind of things that have weird sounds that pop out of the background, your brain is going to alert to them. So they're actually not good. You need something that's called white noise. You can download apps on your iPhone and other devices that have white noise. The other sleep hygiene tip that I think we should integrate with CBT for chronic pain is something called passive body heating. And what this literature is, it's really quite interesting, but there's a stage of sleep called slow wave sleep or deep sleep. And we've done studies, and others people have done studies, that this particular type of sleep is when your brain is most deactivated. It's also when your body secretes growth hormone, and it seems to be really importantly related to feeling restored, and probably really important to regulating the way your brain modulates pain. So if we selectively deprive you of slow wave sleep, your brain doesn't modulate pain. And so if I kind of were to pinch you, that pinching will get amplified by your brain and actually be really strong if your brain is not modulating the pain. And so that when you deprive people of slow wave sleep, that it dysregulates your body's pain control system. So one of the things that you can do is it's sort of like a hack. You can find ways to increase your deep sleep or your slow wave sleep. And there's something called passive body heating. And what you can do is it's all about timing and how your body regulates, thermoregulates. And what you do is you take a hot bath, not so hot that you're going to pass out, but it's like a hot tub type of a bath. Shower generally doesn't work because you've got to heat your core body temperature up about 0.8 degrees. So if you were able to kind of have a device that measures your core body temperature, like a thermometer where you put it under your tongue, if you can heat your core body temperature 8 degrees for a half hour, about 2 hours before bedtime, that improves deepens your slow wave sleep, which in turn should help with your pain. And it's been shown that you can increase your slow wave sleep by as much as 30% doing this simple approach called passive body heating. So the trick is about 30 minutes, but you've got to time it right. It's got to be 1.5 to 2 hours before sleep. If you do it right at bedtime, it actually will make you sleep worse, because what happens is, the way it works is you're artificially raising your core body temperature 2 hours before bedtime, and then that causes a sharper decrease, a cooling, a more rapid cooling. And sleep is related to cooling. And so whenever your body is cooling, you're actually promoting sleep. When your body is heating up, you're actually hindering sleep. So what we do is we move it 2 hours before your bedtime, heat your body for a half hour, and that's what also is nice about that, is it's time to relax, right? And it can help your muscles, and you're relaxing. You're kind of getting in this habit of winding down before you go to sleep, and you're artificially spiking your core body temperature and then causing a rapid cooling. And that rapid cooling is going to promote deep sleep in the first third of the night. And that, we think, we need to do more studies, but we think that's going to translate into improved pain, reduced pain. Next slide. So just one more slide, and I want to talk a little bit about melatonin, because I get this question a lot. Melatonin is another thing that you can do, and I think you might want to think about adding it to CBT, cognitive behavior therapy for insomnia. And so we know that in older adults, there are lots of studies showing that in older adults, often melatonin can decline with age, and certain medications can actually inhibit melatonin. And so there's been lots of studies showing that melatonin taken at the right time can improve sleep in older adults with insomnia. It doesn't usually help so much with younger adults, but with older adults, melatonin has been shown to improve insomnia symptoms. We also know that melatonin has anti-inflammatory effects, and there's been some really interesting work showing that melatonin can have direct pain-killing properties. What we really need to do is some large-scale studies of people with chronic pain and arthritis and rheumatoid arthritis and different kinds of rheumatologic conditions to see whether melatonin can actually promote long-term pain reduction. But there definitely are some studies in fibromyalgia suggesting that melatonin can improve pain, and we know that it improves insomnia. So, how do you take melatonin? And I'll get to the caveats, but relatively speaking, melatonin is relatively safe, especially compared to sedative hypnotics. The thing about melatonin, and why people often think that it doesn't work is either they're young adults and it's probably not going to help in their circumstance, or they're taking it at the wrong time. You have to take melatonin to mimic what's going on in your body. What's going on in your body is that melatonin is secreted about 2 hours before you naturally fall asleep. So if you want to try to improve your sleep, you take melatonin about 2 hours before bedtime. And I would suggest that you look at the label and consider trying to find melatonin, the sustained release melatonin, because melatonin has a relatively quick half-life. It burns up in your body really quickly. And so if you have trouble waking up in the middle of the night or waking up way too early, melatonin in the beginning of the night is not going to help because it will be burned out of your system. And so generally speaking, the doses that you really need are for sleep, generally around 2 to 3 milligrams for sleep. For anti-inflammatory effects, maybe the dosing is a little bit higher. Generally speaking, melatonin has been found to be relatively safe up to 10 milligrams per night. Now, caution, melatonin is not regulated by the Food and Drug Administration. And so the quality of the studies haven't been vetted. And so that's important. And the other thing, because it's not regulated, you don't know what kind of quality you're getting when you go to buy it, because anyone can put whatever they want in it and they're not being regulated by the FDA. So that's an important thing. So if you're going to try melatonin, try to make sure that you're getting genuine melatonin that's made by a reputable company, with the caveat that, it's user beware. The other thing is that melatonin isn't completely benign. If you have diabetes, you really probably shouldn't be taking melatonin. There's studies suggesting that it can dysregulate blood sugar and be problematic in that regard. Melatonin can also disrupt the effects of certain blood pressure medications, calcium channel blockers. And now in terms of rheumatoid arthritis, we know that melatonin is an anti-inflammatory, but there's also some studies suggesting that it's an immune modulator and that it may actually, in some cases, it might be related to pro-inflammation. So it's a little bit less clear whether someone with rheumatoid arthritis should be taking melatonin. What I would suggest you do is talk to your rheumatologist about that, and then if you take it and you're having problems, don't stop taking it.
Okay, thank you, Dr. Smith. Our second guest expert is Dr. Catherine, or Katie, Siengsukon. Dr. Sianzukon earned a master's degree in physical therapy from Rockhurst University in Kansas City, Missouri, and a doctorate of philosophy in rehabilitation science from the University of Kansas Medical Center. She is the director of the Sleep, Health and Wellness Laboratory at the University of Kansas Medical Center and has advanced training in cognitive behavioral therapy for insomnia. Her research seeks to understand how sleep impacts function, learning, and overall health, particularly with aging and in those with neurological conditions. She possesses a clinical background in outpatient physical therapy, treating individuals with musculoskeletal and neurologic injury. Katie, welcome, and thank you for joining us tonight.
Hello and good evening. I really appreciate the opportunity to be here and to present this information to you. So the objectives that I'll be covering in my talk, I think will complement Dr. Smith's talk very nicely. Some strategies that he's mentioned, and then some other strategies to enhance sleep, including a particular emphasis and focus on exercise and physical activity. I'll also talk about body positions for sleep, and also overcoming common barriers to incorporate new sleep habits. Next slide, please. So we know that we spend a third of our lives sleeping, which is a very long time, and we spend a lot of time sleeping. And even though it appears that we're not doing very much while we're lying there sleeping, what we know is that our bodies and our brains are actually very active while we're lying there sleeping. So there's a lot of processes going on that are important for recovery and support of the neurologic system, the cardiovascular system, our metabolic and endocrine system. So we know that sleep is a really critical piece of overall health and wellness. And as a physical therapist, we oftentimes really focus on exercise and physical activity, which is, of course, a very important piece for health as well. But as our profession and also healthcare in general is moving more so to health promotion and also a bigger emphasis on prevention, the physical therapy profession is also starting to incorporate sleep as well as nutrition into our practice. But of course, we do continue to focus on exercise and physical activity. Next slide, please. So I do want to spend then some time talking about strategies that you can incorporate to enhance your sleep. So I refer to them as sleep health promotion techniques. You'll notice that there's quite a lot of overlap in what Dr. Smith has talked about. He's talked specifically about CBTI. And what I've done is I've gleaned some of those main tenets from CBTI and incorporate them into what I call sleep health promotion techniques. So we'll talk about ways to entrain your circadian rhythm. Dr. Smith talked about the suprachiasmatic nucleus and the clock. And so for humans, we're on basically a 24-hour schedule. So we have some hormones that are upregulated during the day, some upregulated at night. And of course, melatonin is one of the primary hormones that regulate our sleep-wake cycle. And so we'll talk about ways to entrain circadian rhythm. We'll also talk about ways to increase your sleep drive. And Dr. Smith referred to that as your homeostatic drive. That's the same concept, is that you want that sleep drive to be super high. So that way, when you get into bed at night and you're attempting to fall asleep, that sleep drive is really high so that you can fall asleep hopefully quickly and easily. And that is also well aligned with your circadian rhythm. So again, you're able to fall asleep quickly and easily. So while our circadian rhythm and our sleep drive are the two physiological drivers of our sleep, we also have to consider our arousal system, particularly our sympathetic nervous system, which you've maybe heard referred to as our fight or flight system. So we also focus a lot on relaxation techniques in order to help dampen that arousal in that sympathetic nervous system to help hasten falling asleep or getting back to sleep if you do wake up in the middle of the night. I'll also touch somewhat on what's called sleep hygiene techniques. So those would be environmental ways and other behavioral ways to help enhance your sleep. Next slide, please. So as far as in training your circadian rhythm, Dr. Smith has talked about this, about light being a really important driver for our circadian rhythm. There's a direct connection from your eye to that area of the brain that regulates our sleep-wake cycle and secretes melatonin. And so basically, exposure to light tells our brains it's time to wake up, and that light tells our brain it's time to wake up, and dark tells our brain it's time to be asleep. So one of the best things that you can do is when you wake up in the morning at the time that you want to be awake, is this to expose yourself to bright light first thing in the morning. And then the other thing is to make your bedroom or where you're sleeping as dark as you possibly can. So light equals wake and dark equals sleep. Another really important recommendation for strengthening your circadian rhythm is to have a regular sleep schedule. And a particular emphasis should be on a regular wake time, which Dr. Smith also mentioned. And that because that helps to set that circadian rhythm. And then of course you're exposing yourself to bright light first thing in the morning. So that really tells your brain it's time to wake up and be active and no longer be asleep. And the reason that I don't and others don't oftentimes emphasize a regular bedtime is because of that concept of stimulus control. We really don't want you to be in bed unless you are fairly sure that you're going to fall asleep quickly and easily. So when I am working with clients, we usually negotiate a regular wake up time, and then we'll oftentimes have kind of a window of when that bedtime might be. With the caveat of not going to bed until you're fairly sure that you're going to be able to fall asleep quickly and easily. Next slide, please. Dr. Smith has mentioned this concept of stimulus control, meaning that we want your brain to associate your bed with being awake, and not we want your brain to associate your bed with being asleep and not with being awake, and certainly not with being anxious or worried about not sleeping. So as Dr. Smith mentioned, if you're not able to fall asleep within 15 to 20 minutes, or you start to feel upset or worried or anxious that you're not sleeping, I recommend for my clients to get out of bed and ideally to go to a separate room if that is possible. I recognize that not for everyone that is possible. You may not have another room to go to. There may be reasons that you're not able to do that. But that is ideal if you can. And ideally, what I recommend is to have what I call a cozy nest, which is the best term we've come up with so far, so that you have a planned area to go to, and you have a mildly pleasant, relaxing activity to do. So it could be watching TV, it could be reading a book. Again, ideally, keeping the lights down very low. I'll sometimes recommend listening to music, listening to a podcast, listening to a book. So that way you're not having to turn a light on or you're not having to have a very bright light on for sure. I do also recommend that it's only mildly pleasant because I have had instances where clients are getting out of bed to do stimulus control, but then they get really engrossed in this really fantastic book that they're reading. And then before they know it, a couple hours has gone by and they haven't gotten back in bed to go back to sleep. And if you're not able to get out of bed, either because that's not an option for you, perhaps physically, perhaps environmentally, that's just not possible to do, you certainly can perform relaxation or distracting activities in the bed. And so for some of my clients, I do recommend that if they're at a risk of falling, or if it's just really not feasible to do that. But if that's the case, I recommend that they sit up, that they change their position, so that way it's clear to their brain that they're not trying to sleep. But again, they'll do some relaxing activities or some sort of a mildly distracting activity. Next slide, please. So this is the other concept. So we talked about trying to strengthen your circadian rhythm. The other area you want to focus on is to try to strengthen your sleep drive, or that homeostatic need to sleep. And I like to think of it as like a balloon. So you want that balloon to be really full and really big. So that way when you get into bed, you fall asleep quickly and easily. So Dr. Smith had mentioned having no naps. I generally recommend limiting naps because I do recognize that for some of my clients that they need to nap for various reasons. Perhaps they have a lot of fatigue, perhaps they had a terrible night of sleep, And so I am a big believer that my clients know their bodies best. And if they feel like that they need to take a nap, then by all means take a nap. But just know that if you do take a nap, you may have to delay your bedtime to compensate for that sleep drive, then dipping. You need the sleep drive to build back up. And if you do nap, I also recommend trying to limit it to 15, no more than 30 minutes, and doing it as early in the day as possible. So again, that sleep drive or that balloon has time to build back up. The other thing I want to point out too is, rest breaks. Rest breaks are not the same thing as naps. I work with a lot of clients who have multiple sclerosis, where fatigue is a very big issue for those individuals, and they oftentimes need rest breaks during the day. And my general recommendation, though, for those individuals and for people with arthritis as well, would be if your intention is to sleep, then by all means do that in your bed. But if your intention is not to sleep, if it is to rest, then ideally you're not doing that in the bed. Because again, we go back to that concept of stimulus control, that if you're in bed, ideally you're sleeping. The other thing to think about is physical activity and exercise. We know that both of those are great ways to increase your sleep drive or to fill up your balloon. And also being cognitively active. So those are other strategies to help increase sleep drive. Next slide, please. And to spend a little bit more time on physical activity and exercise, there have been multiple studies and meta-analyses at this point as well that show that both acute and chronic exercise both have a positive benefit on sleep. It can increase that slow wave sleep, which is that deep restorative stage of sleep. It also increases total sleep time, and it reduces sleep latency, which refers to the amount of time it takes to fall asleep. There was also another systematic review that was done specifically looking at exercise in middle-aged and older adults who have sleep problems. And while there were only 6 studies included, the conclusion was that those people who were exercising had improvements in their sleep quality, and again, fell asleep faster, and also were able to reduce the amount of medication that they were taking. So there does seem to be a benefit of exercise and physical activity to help you sleep better. Next slide, please. And a question that I get asked quite a bit is, when can I exercise, and do I need to worry about exercising too close to bed? And the general recommendation is to avoid moderate to vigorous exercise 2 to 3 hours before bedtime, because there is some evidence that doing vigorous exercise can increase your body temperature and might interfere with that natural decline in your body temperature that typically occurs in the evening and helps you fall asleep. But there was a big poll in America that was done that found that there was really no difference between people who exercised less than 4 hours or more than 4 hours within falling asleep. And so their recommendation really is that exercise is good regardless of time of day. And that's what I generally follow as well. Exercise has a lot of positive health benefits, one of them being that it can help you sleep. And I have yet to have a client who is doing exercise where that it was interfering with their sleep. Now, if you are doing vigorous exercise and you're doing it close to bedtime and it seems to be interfering with your sleep, then obviously you might need to move that earlier in the day so that you're still getting the benefit of exercise, but it's not disrupting your sleep. Next slide, please. And I do want to take just a moment to talk about fatigue. We know that sleep and fatigue are associated. They're not the same construct. They're different things, but they are certainly related. And there are studies now, these are the 2 citations I have are meta-analyses, meaning that they're the analysis of multiple studies, and they have shown that exercise and physical activity also reduce fatigue in people specifically with rheumatoid arthritis, because we know that fatigue is particularly an issue in people with inflammatory arthritis, including rheumatoid arthritis. So how could you get started with exercise? I would certainly encourage you to talk with your doctor, your physical therapist. If you are interested in starting a new exercise or physical activity program, it's certainly recommended also to mix flexibility, aerobic, and strengthening exercises in your exercise program. And then making sure that you're exercising at a comfortable pace and progressing slowly. And also, most likely recommending low impact exercises. So like walking, swimming, and water aerobics. Next slide. And we also know that other types of exercise or physical activity, being meditative movements, so like Tai Chi, Qigong, yoga, those also appear to help improve sleep quality in a variety of populations. But likely these meditative exercises are through a different mechanism of action. It's likely that they are reducing that sympathetic nervous system activity, and so that they are involved with reducing that pre-sleep arousal. Next slide, please. Another important concept to help reduce that pre-sleep arousal is to develop a relaxing bedtime routine. So just like we want your brain to associate the bed with sleep, we would ideally also like your brain to associate that relaxing bedtime routine with what comes next is the bed and thus sleep. And so there's no magic answer for this. You really want to find something that works for you and then be consistent with it. Short and sweet is great. And one recommendation is to get off the screens an hour or two before bedtime because of that, both the arousal with the content, but also the arousal with the light can interfere with that melatonin production. Dr. Smith had mentioned that a warm bath may particularly be helpful for people with pain because of that passive heating of the body then elicits a cooling response. Next slide, please. And then, yes, we want you certainly to consider a relaxing routine, but then it doesn't stop right before, or it shouldn't only be right before bedtime. I encourage my clients to practice relaxation techniques during the day. So that way it's not something that you're just doing right before bedtime, and then it becomes a strategy to sleep. What we want it to be is where it's a strategy to help you relax and to reduce that arousal. And again, practice makes perfect, and you really want to find what works for you and being consistent. The three that I typically do with my clients is deep breathing. We call it 5-7-8 breathing, where you breathe in for 5 seconds, you hold it for 7, you exhale for 8. We focus a lot on mindfulness, and then also progressive muscle relaxation. But there's lots of different types of relaxation techniques. Mental imagery is another one that I sometimes use with clients. And then for some clients, I also will recommend journaling, or we'll talk about that as a possible strategy. And journaling can be different things for different people. Some people use it as a to-do list. Some people want to focus on gratitude. Some people need to process the activities that have happened during the day, or plan for the next day or for weeks to come. So really journaling can take many different forms, but it does help to kind of process and help relax people. Next slide. And we've talked a little bit about this to reduce the stimulating activities before bed, and that does generally recommend getting off screens 1 to 2 hours before bed. One is because of that stimulating content, or it can also be really engrossing so that you don't realize that an hour or two has gone by and you now have missed your bedtime. But then there's also some concern about the blue light that can get emitted from electronic devices, and at least in younger adults, may reduce the amount of melatonin that gets produced. Next slide. And then being cautious about caffeine. This is probably something that you're already aware of, is to try to avoid caffeine, both in food and drinks, at least 4 hours before bedtime, because of course, caffeine is a stimulant. And also really be cautious about decaffeinated beverages or foods, because decaffeinated does not mean no caffeine. And so I oftentimes have to talk to clients about, setting a time that they'll no longer ingest caffeine during the day. Next slide. And then other things to consider is alcohol and smoking. Smoking is a stimulant. It can also result in difficulty falling asleep. And alcohol, I think, is one that there can be some misconception about that. Yes, alcohol may help you relax and may help you fall asleep, but it actually can reduce the depth of your sleep, and you can wake up more times throughout the night. So limiting alcohol to 1 drink at the most is ideal to help with your sleep. Next slide. And then being cautious about large spicy meals, avoiding those because they can interfere with your ability to sleep and make you uncomfortable. And then being cautious about liquid. This is oftentimes, especially in clients who are older, who have to get up to go to the bathroom frequently throughout the night. Of course, you don't want to be dehydrated by any means, but trying to avoid any excessive liquid 2 to 3 hours before bedtime. And then ideally, I'll talk to clients about, how to, if you do have to get up to go to the bathroom, how to keep the environment as calm and relaxing and as low light as safely possible. Because we want you, of course, if you get up to go to the bathroom, to then be able to get back into bed and fall asleep quickly and easily. So if you need to turn on a light, obviously for safety, then do that. But ideally having a low wattage bulb if possible, removing any things that might trip you like obstacles or rugs, and then ideally having a phone nearby if you were to fall and need to call for help. Next slide. And then Dr. Smith has talked some about this, trying to keep the light out of the bedroom because the light tells your brain it's time to sleep, and then also reducing as much noise as possible. So using a white noise machine or using earplugs, an eye mask. I just use a t-shirt over my eyes. It's very simple to use. And then temperature is something else to think about. You don't want to be too hot or too cold either, but generally a slightly cool environment is optimal for sleep. And then thinking too about your pillows and your mattresses, you want them to be comfortable and you want them to be supportive. So unfortunately, oftentimes it's the higher quality, which means more expensive mattresses that do provide superior support. So I usually will tell people, spend time on the mattress before you buy it, and you want it to be comfortable and you want it to be supportive. And I have a couple pictures showing some positioning as well. Next slide. And here we go. So generally, as far as positioning, you want to avoid sleeping on your stomach because that makes you turn your head to one side, and it puts a lot of strain on your neck. So that's generally not recommended, and also puts strain on your back as well. If you do sleep on your back, I generally only recommend sleeping on your back as if you are at low risk for sleep apnea, because if you do have sleep apnea or you're at risk of sleep apnea, laying on your back can actually add to that closure of the airways. But if you do sleep on your back, making sure that you have your spine ideally aligned. So you don't want the pillow to be too high to where your neck is bent up. And you might want to consider putting a small pillow under your knees because that helps reduce some of the stress on your low back. Ideally, I have people sleep on their side, and you want, again, your spine to be fairly well aligned from your neck all the way down to your back. So again, you want a pillow that helps keep your neck aligned. So again, you don't want to be too small or too fluffy, or that changes the bend of your neck. I oftentimes will have people roll up a towel and stick that at the base of their pillowcase, because then that towel can help support their neck as well. And then considering to put a pillow between your knees. So that way, again, it helps to keep your spine as aligned as possible. The thing with positioning, I sometimes have people use all these pillows or all these, kind of commercial devices. And the thing with that is that, yes, maybe you're going to fall asleep, but we move while we sleep. We roll, we turn. And if you have your bed all really well set, if you're going to turn, then you have to get that all set up again. So the simplest you can make it is ideal for sure. Next slide. And I'll touch very briefly, because we do want time for question and answer, to talk about overcoming barriers. In this here is it's a model called the social cognitive model, or the social cognitive theory, and it purports that there are personal factors, behavioral factors, and environmental factors that all contribute to how we behave as humans. And up top is the personal factors. And so knowledge is one of them. We all know that we should sleep, and sleep is important. We all know we should eat better. We all know we should exercise regularly, but knowing is not changing behavior. If I had $1 for every time one of my physical therapy students said, "Oh, I'll just educate them on the importance of exercise," it's like, well, education is important, but that's not necessarily going to make them do it. So really working through, what are your thoughts about performing this behavior? And in this case, we're talking about sleep. What are your attitudes about sleep? What are your expectations? I have a lot of clients who put really high expectations on their sleep, which then is really counterproductive because it makes them anxious. And then some people have to develop behaviors, meaning that they need skills, they need practice. So we set goals, and I have my clients set very small goals, so that can help build their self-efficacy, and then we progress towards larger goals. And then thinking about the environment. The environment is something I think we oftentimes overlook. But that's so important, particularly for social support. If you have family, if you have a spouse, if you have children, you have friends, you have neighbors, whoever can help you on this quest to change behavior, to help you sleep better, then certainly get that support from those individuals. Next slide. And then I think I have this one and I think one more. So ways to then build self-efficacy. So meaning you have that confidence where you can perform that behavior. So being really mindful about your emotional state. This is where mindfulness becomes really important. I have a lot of clients who are very anxious and very worried about their sleep, which then of course is counterproductive. So working on mindfulness can be very, very helpful. Working on, we call positive change talk. And this is not me, the therapist, the healthcare provider, encouraging you to change your behavior. This is you, the client, talking to yourself in a positive way. So there's strategies to do that. And then having vicarious experiences. So observing people who are sleeping better, having stories be told about sleeping better, having models who are modeling good sleep behaviors can be very helpful. And then mastering these experiences. And that's where goals come in, and having very manageable goals that then propel you to other goals. Is helps to build that self-efficacy, which then leads to positive behavior. And then my last slide. So really connecting with your why. That's oftentimes the first conversation I have is, why do you want to sleep better? What's in it for you? And oftentimes we come back to that because sometimes these techniques can be hard, and particularly what Dr. Smith talked about, the time in bed restriction, the stimulus control, that can be really hard to stick with that. And so sometimes if we can encourage people to remember why they want to sleep better, it can be really powerful. And then what's your desire to change your behavior? That kind of gets into your why as well. We refer to this theoretical model of change. There's a lot of people that are contemplating changing behavior, or maybe they're preparing to change a behavior, but they're not quite ready to take that action to change the behavior. And there's strategies that therapists can use and healthcare providers can use to kind of help move you along that stage of change. And then I can't stress support enough, both social support, professional support as well, using mindfulness to connect with your thoughts and your emotions about that change, and then setting those realistic small goals where you then accomplish them. It helps to build self-efficacy, and then you can set other goals to help move you along. And then the last thing I want to end on is to be kind to yourself. I see a lot of people who are very hard on themselves and put a lot of stress to sleep better, and that's very counterproductive. So sometimes I'll have to say, would you say that to your friend? No, the answer is, so please don't say that to yourself. Or how could you reframe that so it's in a positive way? So I'll leave that as my final note, is to be kind to yourself. Thank you.
Okay, thank you, Katie, and thank you, Michael, for your presentations. We are now going to move to the questions section of the event, where we open up the floor. We're going to start with some questions we received before the webinar, but we encourage participants to also type any additional questions that you might have in the Q&A chat box on the bottom of the screen. Please keep in mind that we've received many questions before and during this webinar. We're going to do our best to address everyone's questions, and we're going to answer the most common questions first. So I'm going to start off with a question for you, Dr. Smith. And this question says, it doesn't matter how much sleep I get, I still feel fatigued. How much of this has to do with my arthritis and medications, and what can I do about it?
Well, I think that's a really important question, and I think the answer to that question is gonna require some real thought and I would say consulting with your doctors to sort of figure that out. Could be it's hard for me to know what could be causing your fatigue despite getting adequate amounts of sleep. It could be that your sleep is shallow or that you have a sleep disorder like, say, sleep apnea, for example, where you might be getting lots of sleep, but it's not good quality sleep, and so you're fatigued. But the fatigue could be related to your RA, like you suggest. The pro-inflammatory cytokines cause fatigue and decreased mood, negative mood. So there's so many different factors. So I would say that's an important question. You need to work with your healthcare team to sort that out. And it could be multiple things, including possibly a sleep disorder.
Okay, so our second question is for you, Katie. The question is, I feel so tired during the day, but I can't fall asleep at night. What can I do?
That's a good question, and unfortunately not terribly uncommon. We refer to that as tired but wired, right? Like you want to fall asleep and you're tired, but you can't. And so for those individuals, I spend a lot of time with those relaxation techniques, because oftentimes it's that sympathetic nervous system and that arousal that is interfering with those two physiological drivers of sleep, being your circadian rhythm and your sleep drive, from taking effect and interfering with your sleep. So that would be my recommendation, is to really focus on both a really relaxing bedtime routine, being very consistent with that, so your brain knows that what comes next is the bed and comes sleep. But then also practicing relaxation techniques during the day, because that helps to keep that sympathetic nervous system dampened. So, doing the deep breathing, doing progressive muscle relaxation. Mindfulness is also a very helpful tool to help reduce that arousal as well. And there's some really great apps that can help with mindfulness. But I find for a lot of my clients, working on the relaxation techniques and mindfulness to be very, very helpful for that reduction in arousal.
Great, thank you. Okay, so the next question is for both of you. This question says, I fall asleep easily, but then I wake up a few hours later and I can't fall back asleep. This happens very often. What can I do?
I can go first, and
yeah, sure.
I mean, I think hopefully having some strategies that we've talked about, here, the one of the big things would be practicing stimulus control. So if you're not able to fall back to sleep, getting out of bed and going to that, what I call cozy nest, and doing something relaxing until you feel like you're tired and can fall back to sleep. Because what oftentimes happens is, if you're laying there trying to sleep, the trying is very counterproductive. And then also people get very anxious, they get worried. And we definitely don't want your brain to associate that sense of worry or anxiety with your bed. So that would certainly be one strategy that you could try. And then, doing relaxation techniques when you are out of bed, that could be your relaxing thing that you do that might help to reduce some of that arousal too, and help increase the likelihood that when you do go back to bed, you'll fall asleep more quickly and more easily.
Yeah, I would agree with all of those things. I think the other thing to keep in mind, probably one of the most important things you can do, is it's normal to have bad nights here and there, but you want to prevent that from becoming like a train out of control. And so even if you do have a bad night, I would say get up at the same time in the morning, even if you got poor sleep, and then try to stay up as much as you can during the day. And that's going to make it much more likely that you're going to sleep deeply and soundly the next night at the right time. So that's something that I would stress. But I think doing relaxation exercises or massage, anything that you're aware of that can help in the middle of the night would be worth doing.
And what about when people are waking up during the night from pain?
Well, pain, so I have that chart on pain medications, and I think that's a really important point. It is as important as possible to manage your pain and have adequate pain control at night. So that's really got to be a conversation with your doctor about what can I do, what pain medications can I take and should I be taking at night, because night is an important part of the 24-hour day. And so you should be, if you have to be taking pain medications, you need to make sure that what you're taking isn't going to be impairing sleep as best you can, and that you're taking adequate amounts of it. So some of those medications on that chart are sleep promoting or don't interfere with sleep all that much. So things like the NSAIDs, like ibuprofen, for example, studies show that doesn't seem to impair sleep. And so if that does help your pain, as long as your doctor's okay with it, you should be taking something. But talk to your doctor, because obviously regular use of certain medications like NSAIDs can have their other side effects or other problems like gastrointestinal distress and those kinds of things. But adequate pain management at night is really important. And there are some sedating pain medications that you could consider.
Great, thank you. So one for you now, Katie. We have a question. what can I do to give myself a boost of energy during the day that isn't a sugary snack or coffee? So this is from someone who's dealing with fatigue.
Yeah. Yeah, that's a great question. You know, I would say, you know, ideally not napping. You know, again, that goes back to making sure that you want your sleep drive to be really high at night. So if you can not nap, you know, what I oftentimes recommend is if you can get outside, you know, and that exposure to light can be very helpful. Sometimes doing some light physical activity, again, can really help with that fatigue or that sense of tiredness. I think also knowing that for humans, we have a natural dip in our circadian rhythm mid-afternoon. So I think knowing that there is some normalness to that as well would sometimes helps too. So, you know, getting outside, doing something physically active, getting up, moving around would be some strategies that I would recommend.
Thank you. And one for you, Michael. I have inflammatory arthritis and I experience fatigue even when I don't have pain or swelling. Why is that?
Well, you know, so inflammatory arthritis is caused by a dysregulation in the immune system that can create inflammation. And inflammation, those I call it, they're one of the most common inflammatory markers are cytokines, and many of those cytokines that are secreted by you know, they're embedded in your they're secreted by your white blood cells. They're often embedded within your fat cells, but those pro-inflammatory cytokines cause fatigue. You know, and pain, fatigue and pain. So taking medications to dampen down that inflammatory response and get that regulated should help improve fatigue and mood and pain.
Okay, so following up on that, a question for both of you. Are fatigue and brain fog related, and what can I do about them?
So I think, you know, one thing to think about with fatigue is that there's different types of fatigue, and fatigue is such a, you know, a broad term. You know, so there's physical fatigue, and then there's mental fatigue, or what we call cognitive fatigue. And so certainly, you know, that sense of kind of brain fog could be a part of that cognitive or mental fatigue. And that could be how the fatigue presents for you in particular. And I think to go back to what, you know, Dr. Smith has talked about is, you know, really digging into what is contributing to your fatigue. Is it a sleep issue? Is it a sleep disorder? Is it depression? Is it anxiety? Is it your arthritis condition? You know, there's so much that goes into what's causing fatigue. And so getting to the source of it is really important because it varies from person to person. But then certainly, you know, strategies to help combat fatigue, again, in general, of, you know, exposure to light, being active as best you can, having brief bouts of activity can help with the physical fatigue as well as the mental fatigue.
And another one for you. I fall asleep at 2 to 3 a.m. every night and I wake up around 10 or 11. Is this normal, or should I try to change my sleeping patterns to fall asleep and to wake up earlier?
Is that for me?
Oh,
or
sorry for you, Katie.
Okay. I mean, so if this is something that has been going on for this individual for quite some time, where they're going to bed at 2 a.m. and waking up at 2 a.m. and then 10 a.m. You know, it may be that they have kind of a shifted circadian rhythm. That may be more of their natural circadian rhythm, where they tend to go to bed later and wake up later. You know, I think we've seen some of that be unmasked with the pandemic to some degree, where people now are having more flexibility with their work schedule. And so there's been some unmasking of people's more typical circadian rhythms than maybe would be otherwise masked by kind of social influence and, you know, work influence. But certainly, like if you're going to bed fine and you're waking up fine, you know, at 2 and 10, you're getting 8 hours of solid, good sleep quality, and it's not impacting your ability to work or your social life. You know, there's no need necessarily to shift your circadian rhythm. I think it really becomes a personal decision on if you want to. There's certainly strategies to do that. But if it's working for you and you're feeling well rested when you wake up at 10 a.m., you know, I think that becomes a personal decision.
Okay, one for you, Michael. Do certain medications interfere with sleep cycles or deep restorative sleep? This person is experiencing disruptive sleep with prednisone. And there's also an interest around
Sure.
NSAIDs.
Yeah. So
other meds.
So is the question, do steroids, things like prednisone, does that interfere with sleep? That's the
Yeah, and other general arthritis medications.
Yeah, so steroids can definitely interfere with sleep, but you know when you're taking a steroid, an oral steroid, it's because you have a severe flare of the immune response, and so that needs to be dampened down. And there can be side effects with that. It can profoundly affect your mood. It can profoundly affect your sleep, but it also is an important part of curbing the biologic processes that can be really destroying your joints. So there are times when, unfortunately, you're going to have to take the steroids based on what your doctor is saying, and there could be some side effects. And sleep disturbance certainly is a common one that's reported. Yeah.
Okay. So the next question is for both of you. At best, I sleep 6 hours on a good night, and I always wake up suddenly. I have excellent sleep hygiene. How can I help my brain let me sleep more and gradually awaken?
Well, so one thing is okay. I'll start with this one. One thing is that I don't think I mentioned before is that it's unclear. The amount of sleep that any one person needs is unclear. So there are some people, and I don't know that this person is one of those people, but there are normal short sleepers who can get by with 6 hours, and that's their baseline. It's very rare. It's probably less than 5% of the population, even less than that. But certainly, if you have no side effects, no symptoms, no daytime symptoms, and you feel refreshed, and you're waking up suddenly, in the morning, and you're alert, and then that might be totally normal. You might be just a normal short sleeper. It's unusual, but it certainly happens. So that's one thing to keep in mind. Some of the things that we talked about, if you are having negative effects, so, you're feeling fatigued during the day or cognitive dysfunction, some of the techniques that we've talked about, exercise to increase your sleep drive, may be really, really important. Maybe you're taking naps during the day, and that's causing a curtailed sleep period at nighttime. Maybe you could enhance your slow wave sleep. That might be a way to do it. So those are some ideas. Dr. Katie, I don't know if you have some thoughts on that as well.
Yeah, I mean, I think, yes, that's absolutely. What are the strategies that you can do to increase that sleep drive? Would certainly be a good place to start. And I think it's important to think about the day as a 24-hour day. So I would have that conversation of, what are things that you're doing in the morning and the afternoon to kind of to figure out, what are maybe some of the behaviors or environment that are contributing to that difficulty staying asleep.
Mm-hmm.
Okay, so the next question for both doctors. How effective are sleep tracking apps? So things like Fitbit and Apple Watch apps. How effective are they when it comes to tracking sleep?
Yeah, that's a great question. You guys have a lot of very good questions. So the issue with wearables is that a lot of them have not been validated, so been compared to kind of that gold standard polysomnography. So the issue with wearables is that technology is changing so much and so rapidly that there's constantly new technologies coming out. There's new Fitbits, there's new Apple Watches with new technology. So really research has a hard time keeping up with it. But I would say that the first thing is to be really cautious, because not all of them, and I'd say most of them, have not been shown to be valid or reliable measures of sleep, meaning that they're not terribly accurate. Some are better than others, and there was actually a study that just came out that suggests that the Fitbit actually does a decent job as far as being accurate. But knowing that those wearables, that they are measuring movement, so they have algorithms that say if you're not moving, then it means that you're asleep. So it really is a very indirect way of measuring sleep. So there's a lot of error that goes in with these wearables. So I think that's the biggest message, is just know that there is error. Now, that being said, I think there's a lot of benefits of wearables. I think it's brought a lot more interest to sleep. It's brought a lot of, people more wanting to talk about their sleep. But I do sometimes have clients come in, saying, oh, my wearable has told me that I've slept terrible. And so there can be those kind of, I guess, negative thoughts that come in. But so know that those wearables are not terribly accurate, but they do have some benefit. You can certainly, look at how your sleep changes from night to night, or in general, how your sleep is doing. So there are some benefits to those, but definitely some error with them.
Yeah, I would agree with all of that. The only thing I would add would be, with some of the devices, the newer devices that include the heart rate monitoring, they have pretty advanced technology, and those devices tend to be better than some of the earlier generation devices. So even within Fitbit, some of the older Fitbits aren't as good as the newer Fitbits that have that measure heart rate with something called heart rate variability, which helps them do a better job of trying to estimate sleep. But I think so that's important, that some of the newer devices do seem to be showing promise. I think the other important point to make is that none of the devices are really well validated in particular subpopulations. So, it's very easy to show that a device is very accurate when you're measuring a normal, healthy sleeping person that doesn't wake up in the middle of the night. And those when you compare, so if your device, if you go to bed at midnight and you wake up at 8 a.m. and that's your sleep pattern, the device is pretty good at capturing that, and it's going to say that the Fitbit or whatever it might be is really good. But when that person's waking up for long periods of the night, that's when the error happens, and that's when the devices become less accurate. And so they do need to be validated on populations that have pain or that have tremors, for example. So there's a lot of error in the measurement.
Okay, so my next question is about white noise. Can fans serve as white noise? And is there a machine that creates pink noise for deep sleep?
Yeah, the fans can often work. I mean, the key there is that it's constant. So, and that the fan's not squeaky. But if the fan's doing its job, right, then yeah, fans can be pretty good actually, depending on how loud they are. There are lots of apps that have white noise things you can download for free. Pink noise is a form of specialized form of white noise, and some of the sound engineers think that pink noise is somehow better than white noise, and I'm not sure. I'm not an expert on the differentiating between pink and white, but if you were listening to pink noise and white noise, it sounds pretty similar, at least in my ear, and they both seem to be effective. So those are my thoughts on the fan.
Okay, and this is an interesting one. Can sleep deprivation cause symptoms that could present as a mental illness?
So sleep loss does impact mood. So if we take healthy people that have no mental problems at all, we do a very thorough investigation of them, and we sleep deprive them, and they report negative mood, cognitive function, the fog. They have deficits in their neurocognitive testing, and so it really does impact mood. But that's not the same thing as necessarily having a mental illness, and so they're very different. But we do know that if you have say underlying depression or anxiety, sleep deprivation makes that worse, and a lot worse. And in certain disorders, like for example bipolar depression, sleep loss can actually trigger what's called a manic episode, when people are really unusually high moods with lots of excess energy. And so there is a tight coupling between mental health and sleep, both in people who have no mental disorders, and then also in individuals that do suffer from mental disorders.
Okay, so we've got 2 more questions. The next one is about sleep aids. So the question is it safe to consistently use over-the-counter or prescription sleep aids like Ambien or Lunesta? And what about, trazodone? Yeah, trazodone, I think. And yeah, So sorry, let me reread that. Is it safe to consistently use over-the-counter or prescription sleep aids like Ambien or Lunesta? And what about trazodone?
Do you want to? I'm happy to answer, or
I'll let you do that, Michael.
Okay. Well, I think I said before that the studies show that these behavioral approaches really are the most recommended, the first line treatments for insomnia. But sleeping pills do have their place, and they're the ones that you mentioned. Those are relatively safe drugs that are under the right circumstances prescribed by the physician. Can be really important for people. Zolpidem is generally safe. It can cause some memory problems if it's not taken with the right dose. It can cause the thing I worry about with the sedative hypnotics, especially things like Ambien and the benzodiazepine receptor agonists, is that when you have mobility limitations, they can affect your mobility, and they are related to fall risks, especially in older adults. And that's one of the reasons why all the major medical organizations don't recommend chronic use of benzodiazepines in older adults, because they do elevate your risk for falls. So that being said, you've got to understand the risks associated with them. So one of the other medications I think was trazodone. That's an antidepressant, and it's in lower doses, it's sedating, and under certain circumstances, it can be a very safe drug, but it doesn't come without side effects and problems, and certain cardiac conditions, it can make it worse. So it's just like any other drug. You've got to, talk to your doctor, read the label, talk to your pharmacist, and really understand the cost benefit. But they aren't inherently evil, but they have to be used appropriately. Was there another medication? The Ambien, trazodone, Lunesta. So Lunesta is very similar to Ambien. It's called a benzodiazepine receptor agonist. It's a newer class of sleeping pills, and so everything I said about Ambien would be similar for Lunesta. That it can be associated with fall risk, especially in older adults. The other thing about those medications are they don't mix well with other medications, particularly depressing medications like other benzodiazepines or opioids, that they can make those effects even stronger and can contribute to some of the really severe side effects, particularly with opioids. So combining an opioid medication, things like morphine or OxyContin or fentanyl, all those medications with a benzodiazepine or a benzodiazepine receptor agonist like Ambien can depress your breathing to the point where you can be at risk for dying. And so that's very serious and very concerning. And none of them should be mixed with alcohol and other depressing drugs.
And just following up on this, if someone's been using one of these sleep aids for a long time, can CBT still help them?
Absolutely, 100%. I'd say 90% of the people that come into my clinic have been using those medications for decades and want to come off, and CBT can help them come off. And often what happens is they're on the medications and they still have insomnia on top of them. So first we just deal with the insomnia using CBT and try to deal with that, and then we can wean them off. There's different ways of thinking about how to approach it. It's very complicated, but certainly CBT can be used to help with that.
And I'll just add to that too, that I've seen a lot of clients too that have been on these sleep aids for quite some time, and it's not being very effective. They're still having insomnia and they really want to come off it. What oftentimes happen is that they become the medication becomes like a crutch, right? Like they're worried if they don't take it, then they're going to have really terrible sleep. But oftentimes it's like, well, you're taking it and you're still not having great sleep. So what if we tried this behavioral intervention? And knowing that CBTI is incredibly effective for a lot of people, and that's why it is, the recommended first line treatment for insomnia. I certainly agree that medications have their place and they should be used judiciously. In my experience, they oftentimes are overprescribed. I think this again goes to not enough people who are trained to provide CBTI. So a lot of times, the physicians oftentimes prescribe medication because there aren't providers that can do that, or that's become kind of a standard practice. But unfortunately, I think that's changing, or fortunately, I think that is changing as evidence about the effectiveness of CBTI continues to come out, and more providers are available.
Okay, so the final question for both of you. Is there a way that we can measure fatigue objectively so that we can determine if it's getting better or worse before we speak with our rheumatologists? It can be really hard to tell what's going on when you're in the middle of it.
So the way we measure fatigue is, we use questionnaires is probably one of the primary ways to measure fatigue. There's some various questionnaires that could be used, and you could certainly take that over time. Sometimes though, there's kind of an effect of filling out the same questionnaire over and over again that can be somewhat problematic. I think there's also, you can keep a log, kind of like we would keep a sleep log. You can keep a fatigue log. That would be another way to track it. We've also looked at, so fatigue really is how does it feel to you? And so when we consider objective fatigue, we talk about a concept called fatigability, like how fatigued do you get performing an activity? So we've done various ways to objectively measure fatigability, where we do a walking test, and we see how far they can walk in the first minute versus the last minute. We've also done repeated grip tests to see how fatigued they are from the first to the last. So those are probably more, what you would do in research, probably less what you would do more so in clinical practice. But certainly, you could keep a fatigue log, you could fill out questionnaires, and you could use that information to provide to your rheumatologist about how your fatigue is changing. I think the important thing too is think about how your fatigue fluctuates throughout the day. I think that can also be helpful. So if your fatigue log is not just a one-time assessment of fatigue, but maybe it's doing, morning, afternoon, and evening would be useful information to have.
Mm-hmm. Yeah, and I would just say fatigue is such a general term, and it's probably comprised of multiple little other types of subtypes of fatigue. And so there may be some ways to measure certain types of fatigue, like I know there's some, and it's mainly for research purposes, but, you can measure motor fatigue, how fatigability your muscles are, by measuring EMG responses to your muscles and stimulating your brain to activate the motor cortex. There are some really interesting research-oriented methods for certain types of fatigue, but I wish there was something more objective.
Okay, so a big thank you to both of you for your time and your expertise tonight. I know that I've learned a great deal more about sleep, fatigue, and pain and how to manage it, and I'm sure that our audience have too.
Thank you so much for having us.
Absolutely, thank you.
Thank you. Okay, so before we sign off for the night, just a reminder that we have several resources and events coming up to help you manage your arthritis. So we have some webinars coming up. We have a Facebook Live for fitness solutions for arthritis, cardio and aerobics. And that's on May the 5th at 6 to 7 p.m. where you can get some tips on ways to safely work out without stressing your joints. We also have supplements, herbs and oils for arthritis symptoms, which is on May the 12th at 6 to 7:15 p.m, where you can learn about the evidence on which supplements, herbs and oils may help with arthritis symptoms and how to choose ones that are safe. And then we have Men in Chronic Fatigue, Overcoming Stigma, Finding Solutions. That's another Facebook Live happening on June 17th, again 6 to 7 p.m, where we have a diverse panel of patients and physicians who will discuss the various physical and emotional effects of managing chronic pain as men. And you can register and learn more about these webinars at arthritis.org/webinars. Also coming up, we have the Walk to Cure Arthritis, and it's walk season for the Arthritis Foundation. Depending on your city, events may be in person or virtual. You can visit walktocurearthritis.org to learn more. And we have the JA conference and JA camps. These are going virtual this year as well. For more information and to register, go to arthritis.org/JA conference, or you can also go to arthritis.org/JA camps. We have the Live Yes podcast. So if you haven't already checked it out, check out this Arthritis Foundation podcast, which brings you the latest in disease management and treatment. Visit arthritis.org/liveyes/podcast to listen. And then we have our Live Yes Connect groups and online community. So the Arthritis Foundation runs some online community forums that will help you connect with peers and experts, including virtual support groups. You can learn more about this at liveyes.arthritis.org. We also have the Arthritis Foundation helpline, and you can see the number up on your screen there, 1-800-283-700. And you can call this number, or you could also submit questions online for personal solutions to your arthritis issues. And then we have a reminder about the Insight programme. So you can take your Insights assessment to help the Arthritis Foundation deliver more events like these at the arthritis.org/liveyes/insights. Okay, so as a closing reminder, please note that in a few days, you should receive a survey asking about your experience. Please take the time to fill the survey out completely and honestly, so that the Arthritis Foundation can best serve you in the future. Thanks again for joining us tonight. Take care.